and thank you for staying. It's been a long day, but it's been very productive. So I'm very pleased with the attendance today because we're not sure how many RESNA participants will come to our State of Science. It turned out to be quite a significant number. So the attendance is between 40 to 50 today, so it's very good. And so in the previous 3 workshops, we discussed about the state of the science, the states of research, and the states of development for each of the 3 broad goals of this RERC, which is ICT access, accessibility, and then using mobile health for empowering people with disabilities and reaching people with disabilities who live in rural and underserved areas. So we have reviewed the latest states of the science and then present the works that we have been doing at the RERC of ICT access, and then we also have discussion from outside, Clayton, Devbren, and Mohan contributing to that. So in this last session, the format is different, so we don't discuss the states of the science and then our research and then outside discussion. So the format on this one is more of broadening widening our perspective. So the speakers, Andrea Fairman, Beth Skidmore, and Mohan will present their take of the overall theme of the ICT access and probably also project to the potential areas of research in the future. So, and then, others, Clayton and Devbren, and will also free to contribute as well as a free-flowing discussion. So without further ado, Andrea will present first, and then Beth Skidmore, and then Mohan.
Thank you, Bang Bang. So originally when Bang Bang asked me to do this and I looked at who else was talking, I saw Brad and I saw Andy, and I thought, what am I going to talk about? Because I know what they're going to talk about. And that would be the same thing I'm going to talk about. So instead what I decided to do was do something a little bit more reflective in nature. And to have that reflection has actually changed throughout the day a little bit as I've heard other people talk. And so what I'm going to say is sort of off the cuff, but my journey into mobile health actually started before I ever got into research, I think. Before I even became a clinician, I would say. So before I was a clinician, I was a family member. Both my mother and father have disabilities, as does my brother. And so I had the perspective of a caregiver and an advocate before I became a clinician. And I grew up in a tiny little town in western Pennsylvania called Rural Valley. That kind of says it all, right? Rural is in the name of the town. So people there received services at this tiny little clinic by a primary care physician, and maybe it was what they needed, or maybe they needed to make the big trip to Pittsburgh, which was a really big deal for someone in Rural Valley, including my family. So as I became more involved and my career progressed, my first job was in clinical care was as an intensive case manager for persons with serious mental illness and developmental disabilities. And in that job, which I will say to this day is still probably the most favorite job I've ever had, I got to go with people out into their natural environments and help them where they lived, where they worked, where they played, where they went to school. And I got to see how they really live their lives, and as a result, I got a chance to help them change their lives in a way that's very different than our clinical care systems work today, especially for persons who are working in rehab or in very acute settings where the time that you can provide services to someone is brief. often doesn't happen at the time when you really could make the change at the best possible opportunity, and often is sort of fragmented. So in conjunction with that, I'm going to share with you something that I've kind of thought about as the future of how mobile health can impact our healthcare system. And some of this is maybe a little pie in the sky, I have to admit. But back when we started working on the I'm Here system, I can remember Brad and I standing in front of an audience of clinicians, and this was in about, I say, 2008 or 2009, and we said, we're going to make an app for people with spina bifida, and they're going to use it, and we heard from the audience, they can't use an app. And it was because the clinicians themselves weren't yet familiar with the technology. They were not comfortable with the technology. And so they assumed that persons with disabilities wouldn't be comfortable with the technology. And so I don't think we should make those kinds of assumptions, and we shouldn't make assumptions about where the technology is going and how it's converging. That in particular, I think, is very important. So right now, we don't really have a healthcare system entirely. We have a sick care system, right? So people go to the doctor when they get sick. People get services. Things are covered when things get really bad, oftentimes. If you want to do preventative kinds of approaches, some of that is in place, and it's definitely starting to grow, and it's starting to take hold within our healthcare systems. But much of it is really reactive in nature. As a result of it being reactive, it's also very fragmented or episodic, right? So you get that service in this little finite period of time. Assessment happens in this little bit of time, and you don't get the big picture. And as I thought about this in working in communities and in homes with people, and then my experience of what that was very different from my role as an occupational therapist providing clinical care, I thought about all that I missed if I saw somebody in an outpatient setting or in an acute setting that I didn't get to see when I was with them in their home. And I'm just going to give an example of a client that I was referred, and this is before I became a therapist, and again, rural western Pennsylvania. Okay, so this is an extreme example, but I was referred to meet with this family who the child had had many problems in the school setting, and there were concerns about what was going on at home, and so a home care visit was recommended for this particular family. I went there, and the funny part of the story is that I did an evaluation, kind of a safety evaluation as part of this, because there's also an older adult living in the home, and no plumbing. A chicken actually popped out of the floor at one point. But the most concerning part was that the family had a tent set up in their living room, and they were sleeping in that tent with a kerosene heater in it because they had no heat. So as a therapist at that point in time, where do you start with that, right? So there was so much going on in this situation that was far above and beyond the needs of this child with a disability that the family needed all sorts of services. And having had a background in case management, I understood the complexity of where we needed to start, really, to make a difference. And so when we see only these little snippets of people's lives, oftentimes we don't get a chance to really intervene in all the ways that are extremely meaningful and can truly make a difference. So one way to be able to really help encourage the participation and to provide some of that information is to give people some of the power back, to be able to include information that they're bringing with them to their visit that is accurate, that is reliable, that it shows trends and information. And that's how I'm going to talk about how we can take the control from the provider who has that control in that little session to giving some of the control back, or much of the control back, to the client, the consumer, and what we often term the patient in our current healthcare system. So what we see is that one potential venue for this is mobile health. So while back in 2008, not everybody had a mobile health system that they could access, this is certainly changing. And in fact, not only are more individuals using mobile devices now than any other device, there are actually a percentage of our population right now who consider themselves or would be described as being smartphone dependent. And these are mostly younger persons, but also low-income persons or persons with disabilities who do not have the service in their home. So the only access they have to the internet is through their smartphone device. And we see that that is actually beginning to grow over time. And because it is more cost effective, and you can use this one device to access everything, many people are choosing to spend the money on the smartphone in that plan versus having Wi-Fi at home and or multiple devices. So the other thing about the mobile devices is that they are ubiquitous. They are always on the person. They are always connected, unless you're in these very rural areas. And I will say that my mother still does not have Wi-Fi at her house. So there are still these places within our country that do not have them. And the last speaker had some examples of that too. But I do expect that will change because it has certainly lessened over the last 10 years or so. The other thing is that data shows that 91% of persons with disabilities currently do own mobile devices. The other thing that I've kind of focused my research on recently is that there's a population of persons with disabilities who are particularly good candidates for this, and this is the transition age youth. Because they are very tech savvy, they're keen to use these systems, they also present with some unique challenges because they're trying to navigate and move from a pediatric care system into an adult system. And the pediatric systems and the programs that are in place are often more intensive and more supportive, plus you have the support of your caregiver, your natural caregivers and or other service providers within the educational system. And then they're moving out to the adult care systems, which are even more fragmented in many instances and don't provide the same level of supports that they did at those younger years. So this population in particular is not only at risk, but they're also more keen to use the systems. And there's some examples here of some of the research that we can see that 94% of young adults are using smartphones. We see actually declines in self-management during those teenage or transition years. A lot of times those barriers can be mediated by using some of the mobile health technologies to help support performance of these tasks, and they can be made fun and engaging, which is also really critical for engaging the individuals in long-term use. The other thing that's happening in conjunction with this is that not only do we have the potential of input of information from these apps, but they can also be paired with wearables. And the mainstream wearables are obvious. They have proliferated over recent years. This is just a picture of an aisle in Best Buy. And it gives you an idea of how many different devices are commercially available right now to the average consumer, right? So the unique thing about wearables in conjunction with mobile health, and one thing that I think will make it much more powerful in the future, is that this information can be automatically captured. The person doesn't need to sit down and enter it. And that's really key to the success of a lot of these systems because you don't want to spend a lot of your time entering this information. I recently myself tracked all of my food and all of my exercise, and I found how tedious it was to do that, right? To have to constantly enter that information. Pair that with having potentially a cognitive disability or other demands on your life and your time, and it's just not going to happen. So we have to be really careful about what we're asking people to input into these systems on a regular basis to provide the types of meaningful data that can actually guide their health care. And in instances where we can gather data that is automatically captured by sensors and wearables that go in conjunction with those, that makes the system even more powerful and more reliable. So those are examples of mainstream devices, but there are also some examples of ways that we can include sensors in medical devices. And this particular app was created to be used in conjunction with a baclofen pump for someone who has spasticity, so that we could capture that data automatically from the pump about how the person was doing and record that app and provide that information back to the physician to see what progress was being made, or what problems are evolving for this person who's on baclofen. And I would like to suggest that maybe there are other ways that we could integrate apps with medical technologies that are sort of part of the person. So many persons who have hydrocephalus also use shunts. Could we have sensors in these shunts that give us ideas about when there are problems that are going on? Could we have perhaps small sensors that indicate when there's an arrhythmia for somebody who's using a pacemaker? So how do we integrate this information that we're able to gather with the medical devices and promote more of a proactive than reactive approach to our healthcare? So as I mentioned earlier, what we really see that is making the difference is the convergence of the technologies. It's not just one thing. It's many things happening all at once and actually quite quickly in comparison to how it was changing. It took us 10 years to get to where we are with the I'm Here mobile health system. But if we were to start today and try to make that same type of progress, we would get so much faster, so much further, so much faster as a result, because the technologies have changed so much. And I think a few people have reflected on that over time, that as the technology proliferates and the change becomes quicker, our ability to make progress also becomes quicker in how we apply this in the real world. So one of the really big things is going to be genomics, and how we can take that information and personalize healthcare based on that, and be able to really use these large data sets and share them across systems, across populations. In conjunction with that, AI is going to allow us to make sense of this information, which is going to be really important because we can't have someone sitting back there crunching all these numbers or analyzing all this. A lot of it will need to be automated in order to be able to use it in an efficient real-world way. And I've mentioned already the wearables and the sensors. So some of the terminology associated with this, and what I've felt is really powerful, is that we now can conduct assessment in a way that we could not previously do. Because persons have these devices in their hands and with them all the time, we don't need a one-shot sort of check-in with a person to see how they're functioning from a cognitive perspective, to see what level of exercise they're able to engage in. We can get this information all the time continuously, and that's actually much more valuable in many instances than that one-shot look. I was thinking about it in relationship to how other systems actually work, and the automotive industry came to my mind when I was thinking about this, because of the snapshot that you can have for your car to see, are you doing well with your driving? Well, are you doing well with your health? Can we get a snapshot of what your health looks like, and can that potentially influence how you receive your healthcare services? Can you be proactive? Could you potentially even reduce your insurance rates as a result of that, like you can with your car insurance? There's incentive there for people to look at those types of processes. But at the same time, we're able to do diagnostics based on this information that we gather too, and indicate when there are problems and when we should intervene in advance, before the problem gets bad, not when it's so bad that we need to have very intensive services that are also extremely costly. So in addition to doing the assessment that way, we can also intervene constantly, right? So it doesn't have to be that one time a week. So a lot of the projects that we looked at today looked at how we could take the traditional healthcare services and provide them at a distance, and if it was going to be as good as that in-person service. That was kind of the focus. Could we have just as good of outcomes as in-person? And I think that's really important and extremely valuable. But I also think that mobile health offers the opportunity to change the way the services are provided and to provide them almost continuously with an automated component and a check-in that can make it actually more powerful than the in-person services that we're able to provide, or add to them in some ways. And of course, we would want to include that with the AI, as I mentioned earlier, because of the large data sets, but also the context is extremely important. So the progress that we've made with GPS and being able to refine exactly when and where things are happening becomes extremely powerful in the conclusions that we draw from this information. So this figure was thrown out a little bit earlier, that there are 325,000 and more. I'm sure that this has even increased significantly since this was cited in 2017, that are available to consumers. People who work in assistive technologies know all about abandonment. So I would guess that quite a few of those apps have been abandoned, right? So they've been downloaded, they've been trialed, maybe they even went through a pilot, and now nobody uses them, right? You yourself may have experienced this with a variety of apps that you've downloaded to your device. You take a look at them, you use them for a day or two, and then they are abandoned. They are no longer used. A lot of what we need to do in order to engage individuals is that long-term sustainable use, and that's not that easy to achieve. We have had some studies, like for instance the I'm Here study, where we had people involved for a year. But really a lot of that, I believe, was that consultation that was happening between person to person. So I don't think that the automation and the app itself is the only sort of component of this solution, but I think it's a piece of it and how it's used in conjunction with programming and the communication between the provider and the client. So again, it certainly is not the cure-all or the magic pill by any means, but I do think it's going to provide some new avenues to change how we're looking at the provision of our health care and move more from a reactive to a proactive approach to care as we use our data to not only empower clients and patients, but also clinicians to have very valuable information that they wouldn't have been able to get otherwise. And just to kind of bring it back in with some of the points that I made earlier and what we often see happening in policy. The triple aim is certainly always a hot topic because we know that funding can come along with that and there is incentive there for clinical providers. But these scalable innovations, the ability to customize a system, to make it very personal and unique to what that individual needs, which is often termed precision medicine, is going to be possible using mobile health. The cloud solutions are allowing us to share this information and to be able to store it and access it across various providers. There's not usually a situation where someone just needs help of this one specific individual. So that family I identified earlier that had the tent in their living room, they didn't need just an occupational therapist to help them. They needed a whole gamut of services to kind of move them through to where they could be functioning at a level that was safe and also help their child. But that requires a lot of sharing of information, and that's not always the most easy thing to do in our current healthcare systems. And then lastly, as I mentioned, artificial intelligence will be one avenue to kind of bring this together and help us make sense of all this data rather than trying to analyze it just through the typical means that we have right now. That's all I have.
Thank you, Andrea.
So good afternoon or evening. I think we're moving towards evening. I'm Beth Skidmore, and I'm professor and chair of the Department of Occupational Therapy at the University of Pittsburgh. And one of the things that I've been asked to talk to you about is what's the opportunity for innovations and interventions that are using mHealth, mobile health. And so my perspective on this comes from the perspective of one who does a lot of thinking about how to design and optimize interventions to promote skill-based training in individuals who have disabilities, particularly for individuals who have cognitive impairments, which is my area of expertise. And by skill-based training, what I mean is helping people identify and resume the activities that they need and want to do in their everyday lives. And so for me, my perspective is not just the technologies, which I think are really important, and we rely heavily on the innovation that's emerging there to help us do that, but also understanding what the theory base is behind the intervention and taking advantage of best practices and best evidence to make sure that the intervention that's being delivered via technology is really optimized for the best possible outcome. So I will start with my story. This young man is a youth pastor and self-employed and a father of 5, and he sustained a stroke at the age of 28 due to a genetic anomaly. As a result of the immediate changes from his stroke, he had full paralysis of his left arm and leg. He had moderate to severe impairments in his attention and executive functions. He was unable to walk, bathe, dress, or do any of the roles that he had as the sole breadwinner in his family. And yet his goal at the time that I met him is to return to all those previous roles, which includes being self-employed, so he lacks a structure to fall back onto. No really model for modified workflow or anything at that point. And yet he has this very short exposure to rehabilitation, right? His length of stay was actually a little longer than the national norm for stroke. It was 15 days inpatient. That includes weekends. He had 12 visits in outpatient, and then he's at home. He's 80 miles from a rehabilitation center. And our job is in that short time to try to help him identify and resume the skills that he needs to do to return to that environment at the highest possible level. And likely we're not going to accomplish it in that time, right? But maybe what we can do is give him the skills that he needs so that once he gets home, he can continue to facilitate recovery. And so, you know, one of the questions that we're spending a lot of time asking as we have less and less access to clients, and our clients have less and less access to the duration of therapy services, is how do we sustain a trajectory for this continued recovery? And so what I did to educate myself, since I do not have a background in telehealth or telerehabilitation or telepractice or mobile health or all the terms I've heard about today, is I took a quick look into see what the state of the science was in stroke. For telerehabilitation services. There was a nice review that was published in 2013. And a couple things that I learned from that. The state of the interventions, and I'm looking at this with my intervention lens on, really comes to the level of case management, consultation, and education. There's some evidence of some interventions using computer or virtual reality programs to stimulate limb function. And then prompting our activities, usually via text, to encourage people to get up and move. And the technologies ranged a variety of areas, and actually it seems like, at least in stroke rehabilitation, video conferencing is one of the least common. Telephone and the in-home messaging, the online chat were a little bit more common without video conferencing. But when I actually looked at the effects of these interventions, again, you've addressed this already, that a lot of the time the state of the science right now is to say, does an intervention delivered through a telerehab model get us an equivalent outcome to that versus in person? And the reality is, with stroke rehabilitation, the story is no different than what you've seen. We see equivalent levels in terms of independence, mobility, limb strength, satisfaction with the types of therapies they received, and overall self-reported health-related quality of life. But the actual within-group effects of those interventions, and let me be clear what I mean, is the actual robust change that happens within each of those domains are relatively modest. So whether telerehab or in-person are equivalent is one question, but in my mind, neither one of them are really great yet at meeting my goal of helping that client return home and resume the activities they need to. So we need more robust interventions, regardless of the mode of delivery, and I do think that telehealth can be a partner in that process, but we need more robust interventions, and so that's the way I've been tackling the problem. And I'll talk to you a little bit about the work that I do. One of the reasons why I think most of these interventions are not really robust is they've not addressed the cognitive impairments that come along with stroke. For many years, we treated stroke and many neurological disorders of similar ilk as motor-related problems. And we focused our interventions on addressing the motor-related and mobility-related problems. And we ignored this prevalent problem of concurrent cognitive impairments. The estimates are as high as 80% of people who sustain stroke are going to have some sort of change in their thinking, which affects not only their ability to do daily activities and resume those activities, but it also affects their ability to engage in and benefit from rehabilitation. We have studies that have demonstrated the direct role of cognitive impairment in that. So we tell people what to do, but their cognitive impairment does not necessarily allow them to internalize that, make it a part of their routine, and carry it forward, right? And furthermore, we don't necessarily always ensure that they understand or retain what we're telling them what to do. So as a result, it's probably not surprising to you that people with cognitive impairments have greater disability, longer hospitalizations, they're more likely to be rehospitalized, much more significant caregiver burden, higher likelihood of ending up in a permanent institution. And even with mild stroke, by this I mean people who go straight home from the acute care hospital with no rehabilitation because they have no obvious physical deficits. Even with mild stroke, they are significantly less likely to be employed 1 year later, because they have changes in their cognition and their mood, which are causing significant problems. And these are individuals that are completely untapped because they're not entering a rehabilitation system at any point. In our center, which is representative of what you see across the nation, it's about 60% of people sustaining stroke are going straight home with no further rehab, because we're doing a better job minimizing that acute insult to the brain, but not necessarily acknowledging the subsequent cognitive and mood changes. So put simply, people with cognitive impairments after stroke, and I would make a case this is also true in cardiac disease, cardiac arrest, and a number of other conditions, critical care populations, they have less independence at the time of whatever medical event they're experiencing, and they also have an attenuated slope of recovery. And that attenuated slope of recovery is problematic, probably because, or it's occurring probably because we're really not optimizing rehabilitation or interventions for their needs, one, or they don't have access to, given the population I just told you about. So this is really a problem that I've been trying to tackle for a number of years. I think it's interesting when I did my little review of the literature that actually this is a recognized problem in the telehealth community. In fact, the telehealth community is a little bit more ahead of it than the non-telehealth community in stroke rehabilitation. And so they're recognizing the need for telehealth approaches to address these cognitive impairments, and these are just a couple of quick papers that I found. There are actually several, but they're talking about the need to envision a model where we can deliver interventions to address cognitive impairments after stroke, and testing a few interventions. When I looked at the interventions that have been tested, they look very similar to the ones we saw in the larger review. They take greater advantage of gaming technologies and so forth, but the bottom line is it looks very similar to what we're doing to address motor problems. And it's too early to tell whether these are making a difference or not, so I don't have a comment on that. This work is in the very early stages. But I'm going to argue, based on what we already know about the use of these interventions, the tele-rehab interventions, case management, consultation, education, prompting, and directing, you're looking at those interventions being used in in-person rehabilitation, we know they are not terribly effective, and there are more effective approaches to promoting skill-based training. So I would argue that we've probably not really realized the full potential of a theory-driven, evidence-based approach to partner with these telehealth interventions. And that's because, at least as we think about addressing cognitive impairments, it's a relatively young body of science. These interventions are still being investigated. A few of them have made it to phase 3, but very few. We have a high emphasis on high-touch interventions when we're talking about addressing cognitive impairments, right? Someone's got to be present, they got to supervise, they got to manage the environment, they need to think very carefully about how they interact with that person. So clearly you couldn't do that through telehealth, right? And we need more innovation, so we need to better understand how people learn, how people with cognitive impairments learn, and what's the best way to deliver interventions with that in mind. And then we've got to address the ever-present safety risk concern, because the minute you say someone has a cognitive impairment, the therapist will stand up and say, impossible to do this at a distance, or impossible to guide someone and let them kind of choose their own way of addressing their problem. So, you know, it means that there seems to be a lot of perceived barriers to the feasibility of delivering interventions to address cognitive impairment using a telehealth model. I'm going to argue that that's not the case, and I'm going to give you a case, but I think to better understand where I'm coming from, I'll give you a brief primer on what the current state of the science are on interventions. So we really have 3 types of interventions that have been studied to address cognitive impairments: cognitive training interventions, aerobic exercise, and strategy training. And I've listed for you, I didn't put all the effect sizes and all the citations on, I'm just giving you the Cliff's Notes right here. The bottom line is, if you'll trust me, based on meta-analyses and systematic reviews, we see modest to very small effect sizes and the benefits of cognitive training. And by cognitive training, I mean exercises, games, those kinds of things that don't necessarily engage somebody in a meaningful daily activity, but are very entertaining and very engaging and highly addictive, according to my clients, when we've measured it. Aerobic exercise, we actually do get small to moderate improvements in cognitive function with it, and we also see translation to improvements in mobility, improvements in self-care. So that's an interesting intervention. And strategy training is another intervention, but what's interesting about it is we get the most robust effect sizes with these strategy training interventions. Emily Kringle earlier described strategy training to you, but basically, in principle, strategy training interventions are designed to not tell clients what to do, but elicit from them good strategies that they can use to address the problems they identify. And it's a very robust approach when it's delivered appropriately. So when I looked at the tele-rehab interventions that are being used in stroke at least, most of them are focusing on this top category, cognitive training interventions or environmental adaptation, prompting interventions to kind of guide people through a task, but not necessarily training them to relearn a skill. And very few, or almost none, have used a strategy training approach. And I think I've given you a number of reasons why that might be the case. We've done in-person studies with strategy training where we've implemented this in inpatient rehabilitation, and we've found that if we do this, we get a significantly better outcome in independence with daily activities using a strategy training approach relative to just usual care. And that's with a very low dose intervention. It's 45-minute, 10 45-minute sessions, and we get a really robust change over time. We just actually finished a trial with 250 people then randomized, and we get very similar effects. So this was an early pilot study. I just didn't have the updated slide for you. The other interesting thing about this intervention is it seems to have a specific effect on executive functions. So what we found is both groups got equally better in attention and memory and language, but our strategy training group showed significantly greater improvements in executive functions. Executive functions are kind of like the holy grail, right? If we can change that, we can stimulate somebody's independence in the community. And so this becomes an interesting intervention to figure out if there's a better way to deploy this to address the needs of Bob, who we see for about 2 months, and then he's out the door and he's 80 miles away. It involves 4 active components. First, the clients set the goals that they want to work on. Their goals focused on meaningful daily activities they want to do. We teach them how to evaluate their own performance. That usually makes therapists a little uncomfortable because they think that clients can't do that and only therapists can. And I'm here to show you that clients do it not only well, but better than we do. And then we use this global strategy, and I think Emily talked about the goal, plan, do, check. There's nothing magical about that. That's just a scaffolding to guide their learning. But the most important active ingredient is the therapist uses guided discovery, coaching, to help the client figure out how they're going to address the problems they identify. And clients pick a variety of activities that you might see there. We use this process very intentionally. The goal when we're doing the intervention is less about achieving the particular goal the client has addressed, although they do achieve their goals quite well, but it's more about learning the process so that if they encounter a new problem, they can apply this process that is a gift that keeps on giving long after we have interaction with them. And we provide both instruction and feedback. We shift along this continuum of control where the therapist relinquish control a little bit in the session and navigate that with the client with cognitive impairment to help empower them and assume more control over deriving their care and their learning. So the question is it possible to support intervention through telehealth? Earlier you heard from Emily Kringle, my doctoral student, that it does look like it's at least feasible. We ran an initial case study with 5 people, which was mostly spent on refining the intervention and optimizing the telehealth platform, showing how they could work together. And we did have to refine the intervention as well as refine the technology, which is an important lesson I want to leave you with, and we can talk about if there's time. We found that it was safe and feasible. The clients enjoyed the intervention. We changed the way we approached goal setting. We changed the way we approached some of the guided discovery. We had to change the way that we approached the check process or the touch-base process. But we have not yet had an adverse effect from this approach. And I think it's because we have used folks who have had the in-person training, and then we've looked at this transition to home, so a hybrid model. Does it improve adherence and carryover strategy training? That's the big question, right? So right now we're administering this in inpatient rehab studies, and they get 10 sessions in the home, and then we turn them loose and follow them over a period of time, but no more strategy training. So the question is, do they keep using the skill that we're teaching them? Do they use that strategy? Can they apply it to new goals? Does it continue to help them get independent over time? Very important questions. So we are in the process right now with funding from the RARC, running a pilot RCT where we're actually in hospital using the app with strategy training, or if a client is randomized to the other condition, they're getting strategy training with our traditional kind of not so great workbook that I developed on the fly. And then we're looking to see the degree to which they use both over time and degrees that addresses our adherence and our carryover of the skill of problem solving. And so far, we've randomized 14 of the 30. So at this point, we've learned quite a bit. The pre-work that we did in terms of optimizing the intervention and optimizing the telehealth to work together was very useful, because we've really required very little changes at this point in terms of those two elements. We're just running the protocol and then following these folks for 3 months and seeing what happens. So far, and the two things that I want to leave you with, is that it is feasible and safe to expand the breadth of interventions that are paired with telehealth, to incorporate interventions that are theory-driven, evidence-based, and that focus on more complex things than just walking through a series of steps. Skill-based learning, which involves a bit of judgment, involves a bit of complexity. And it's also feasible to do this with people with cognitive impairments once we've assured safety. And we've done a number of things in terms of selecting the folks who do participate in the protocol. So we've ruled out a couple of cases. We don't include anyone with dementia, and we exclude people who have really poor self-awareness that are based on a measure. But beyond that, if they show the ability to do this safely within 7 sessions, we let them continue the protocol at home. And as we think about interventions for telehealth, I'm going to make a plug to say it's not only important to think about the technology and the delivery of the technology and the interface of the technology, but it's really important to take a step back and think about the principles of the intervention that you're delivering through the technology. And I think that's been underplayed in this body of research, and I would just encourage us to think about that a little bit more. So I will leave you with the team that put this work together, and turn over to the next person.
Thank you, Beth. So the area that Beth has been and Emily have been working on is quite challenging to implement in using mobile health technology. And but this is an example. It's an example of the area where technologists and therapists and intervention developer work together to, as Beth mentioned, refine both, not only the technology, but also the intervention itself, because the intervention could be very different between the in-person and if it's delivered to mobile health telehealth. So that's the area that I think will be very crucial in the future of both concurrently developing the technology to support the intervention and how to motivate the intervention to use the new medium that allow us to deliver complex intervention that previously can only be done in person. We did it, with I'm here with intense communication between technologists and clinicians, and the same thing with here. So that, and I found that's the most productive way of working together and developing is more of a completely new intervention, and not only just shifting existing intervention using new medium. And in answering Mohan's previous question about why most of the intervention done to rural areas are using video conferencing. I didn't think about it before, but the reason was that most of these projects are done by clinicians who just want to transfer existing intervention using whatever technology that they already have. So an example would be in the VA, they already purchased 125 million video conferencing equipment. Yeah? So they have it out there. They have to use it. So this clinician said, oh, why don't we just use it for stroke? So that's how it done. So it's not the existing infrastructure, is there and cannot be modified. And whether it's appropriate or not, that's another issue. But that's the area that I think in telehealth, mobile health, especially with people with disabilities and with support from NIDAR, is to build a completely new intervention that combines, the evidence-based, theory-based intervention as well as the technology, the new technology, new way of thinking and blending together. So, sorry, Juan.
All right, I'm back. This is an interactive session. As a technology person, I'm going to present a snapshot of the various projects we have undergoing in the hope that it will lead up to some discussions. So what do I do when someone comes to me with a project? They want to do a telehealth intervention, and what exactly do I do with their request? So I usually, there are other ways to classify. Already today we saw several ways to classify telehealth interventions. I look at it through this lens. We focus on increasing physical activity, which is, after the acute scenario, they are no more in the hospital, their short rehab period is over. They are in the stage where they need some help, but not in context to their regular health care scenario. That is our typical case. So we have several projects where they involve live exercise training. So when I say live exercise training, it's through video conferencing, someone providing one-on-one, or recently we have started to do group-based exercise training. Some projects involve live health coaching. When I say live health coaching, it's much like the iAdapt system, wherein it's a long, sustained intervention. There is not really something to show on a daily basis. It's more of health coaching, talking to them, which is usually audio-based, and there's usually a companion website which goes along with it. The website could be just for the participant and also the caregiver, and the health coach obviously have their own portal. And then we have projects where we have pure e-health websites. The user goes to a website, signs up in a website, everything is automized, they use the website, and the project gets done. And when it comes to mHealth apps, already I spoke about one project where there is very little connectivity. We devise the strategies different based on whether connectivity is present or not. When connectivity is present, things become much easier and many more options are there. When connectivity is not present, we work in a very limited scenario, very little features, but robustness becomes the most important factor there. That said, what other factors are so important for us? Safety is the most important thing. We are providing interventions for people with disabilities. You cannot have something where you present a gazillion options to them and they pick a wrong option and something goes wrong. Safety is a very important thing, but at the same time, you don't want it so safe where it is boring. So achieving that balance through personalization features in the interventions is very critical. Is it scalable? We have had projects, where we can spend a lot of time, but is it optimized at the consumer end and the provider end? If there is a telehealth intervention which reduces the travel required for the participant, but then the coach or the therapist needs to spend a couple of hours before the intervention to set up the apparatus, prepare for the intervention just because it's a telehealth intervention. We have optimized on one side, but have made it complex on another side. So it's very important to find that balance. And finally, is it sustainable? It's very easy to sustain a pilot project, but for some of the large trials we have, if we do not optimize it, it's just not going to be sustained. It's going to land up in one of those thousands of apps the earlier presenter was talking about. Right after the project, it's going to go into the shelf. Before I move on, when I say we, our group, the UAB Lakeshore Research Collaborative, we are positioned uniquely wherein we have another center. It's called the National Center on Health, Physical Activity and Disability. It's a resource center funded by CDC. What it enables us is for projects which do not require a healthcare provider's help or intervention, we are able to graduate these projects after a research stage and promote and deliver it through that infrastructure. That said, the projects you will see today are funded by multiple agencies, NIDLR, NIH, PCORI, and CDC. This is a project funded by NIDLR, wherein we implemented online exercise training and monitoring system. This is actually a screenshot from the client's dashboard. This is an mHealth app, wherein the participant is able to view the coach is able to view the participant, and the participant is wearing a bioharness through which we are able to monitor their heart rate and other vitals for safety reasons. The next screen shows the coach's dashboard, and here is a picture of a real participant. The very encouraging result we found from this project is we got an attendance rate of more than 90% for the small set of participants we tested in. Usually the biggest challenge in case of interventions, especially physical activity, if it was in person, given all the barriers, transportation, time off from work, and all the other factors, coming to a fitness center or a community setting and achieving the physical activity goal is very challenging. But in this case, we were able to achieve 90%, more than 90% attendance. That was primarily because we offered very flexible sessions. We offered, sessions can go up to as late as 9 p.m. and weekend sessions were offered, and it really helped. That said, in this same, a similar setup, we now have a project which involves an intervention where exercise based on music, we call it M2M, is being offered. One significant challenge we face, that was a challenge I was discussing to Bam Bang yesterday, the latency, when you want to involve something where two-way video, two-way audio, and all four in sync, it's a huge challenge. So we spend quite an amount of time in the initial phases getting the participant oriented to the delay. So the exercise coach has to understand that they have to keep what they do and the participant has to keep doing what they do. There is a fixed lag, and as far as your brain can process it, you can keep on proceeding further, which is a significant challenge we have to work around. Now we are working towards making this approach sustainable. So we are working on a one-to-many solution wherein instead of one-on-one coaching, we are able to offer preset sessions at different times of the day, and wherein multiple people can sign up on the sessions. The next model of projects we focus on are live health coaching. One system supported by NIDLR is what we call as personalized online weight, exercise, and response system. This is a system where a patient is no more in the care of a therapist. They have sent home, and often what happens is their health trajectory goes down. Once it goes down, that's it, it stays down there. Our hope is that through web technologies, we are able to provide them long-term coaching and training to get them into sustained healthy habits. Therein, they are able to again go back into the community, integrate into the community, and make use of the trainers in their respective community settings. As I told you, we focus significantly on scalability and sustainability. I'm not going to go into every detail of this, but to provide a proper coaching session for a person with disability requires a lot of preparation. You need to know who you are working with, what was their previous goal, what are we working on, where exactly they are. So the system includes a lot of intelligent capabilities wherein the coach has to spend very little time in getting ready for a session. Unless the coach can get ready for a session in a short amount of time, the advantage gained by telehealth on the other side is being lost. So this is a screenshot from one such project where the participants are, providing a log of their physical activity minutes and amount of water they drank based on the goals we have provided. So we have many variations of this project. We have projects focused on kids, projects focused on individuals with intellectual disabilities. One big variation we see is how much involvement do caregivers need to have in this process. In a project we did with kids, talking to the caregivers, which is the parents, did little to no change at all. Because no matter what you talk to the parents, it's not converting as changes with the kids. In another case, when we worked with people with intellectual disabilities, more than the participants, it was the caregivers who really influenced their habits. Because they are in charge of providing the food, they are in charge of their physical activity, and the impact was very different. The next category of projects we focus on are e-health websites. This project, which we call the NICPAD 14 Weeks, is a part of our CDC-funded project. We launched this in 2011 as a fun side little project. Today, we have 25,000 users who have used this particular project until now. And this is one, sustained, scalable system. It took a massive amount of effort. We had 2 to 3 videographers and multiple people preparing almost, I think, 700 different videos. But once launched, there is very little work for us. Monthly we spend no more than 2 to 3 hours of work. And this is one project where we get a lot of feedback on. This is again a project supported by NIDLR. This is a project we implemented. Again, this was a side fun project we played along with. This is like a Yelp for becoming more active. So it takes a lot of effort for a person to find a place to do the activity they like when they have a disability. They can easily find a place where everything is good, but the restroom is not accessible there. It just blocks out that whole opportunity. So what we have implemented here is a Yelp-like system, which we have piloted in Birmingham and surroundings, where the person is able to drill down into precise accessibility choices. When I say precise, they already might know a facility with a swimming pool which works for them, but it was that restroom which was a problem. So they are able to nail down on the precise features of the different facilities. Next, I'm going to talk about some of our mHealth app projects we have going on. We have a scale-up study for people with mobility limitations. This is a project with 850 people with mobility limitations. So when I talk about people with mobility limitations, it's a grouping of people with various physical disabilities. So it requires a lot of personalization. We offer exercises which are personalized based on the functional capabilities of the users. As opposed to specific disabilities, we personalize the exercise activities based on their functional capabilities. In this program, we offer our movement-based exercise program, which was designed by funding provided by NIDLR. We have a 3-arm randomized control trial testing whether the control group, exercise-only group, and exercise plus social networking group. And we are very eagerly waiting for the results from this. We strongly believe that adding social networking features to mHealth apps can promote the adherence. When we talk about social networking, I'm not just talking about app-based social networking. We also have non-app-based social networking. We host weekly health coaching calls wherein a coach goes online on the phone call, and any other participant who would like to get some social support is able to get on the call. So this goes back to, I think many presenters touched upon, just don't launch an intervention automatic, it's done. That regular human touch is very critical. This project we already saw in the earlier presentation, and I think pretty much everyone here was in it, and so I'll skip on that. And that ends a snapshot of the various projects we work on, and I would love to answer any questions you have.
Thank you, man. So we still have a little bit of time. Do you want to comment on it, Clayton, if you have?
Am I first?
Yes.
Okay. Yeah. Well, I guess I can.
Yeah, the other microphone is running out of battery.
So if you can close that computer, I'll put mine on top. Yeah, wonderful presentations, wonderful work, really inspiring. Couple of themes struck me listening to them. One is and I should say some of the presentations earlier today. So one of the themes is the challenge of education. There's so many situations. One that comes to mind is what we were learning about the impact of parental education level on the prospects for children born deaf. So there's a case, but there are lots of others. Actually, one that's on my mind, maybe I'll make everybody uncomfortable a bit. I've just finished reading a review of research on sleep, and maybe everybody but me knows this, but you name something that you wouldn't want to have happen to you, and sleep deprivation will do that to you. So Andrea's nodding, and she may well know, maybe others of you do as well, that there's a link to kind of connect it in one way into what's happening in this room, the interest of many people in this room. Stroke risk is strongly linked with sleep deprivation. Well, the other place this in the room is that we're engaging in the cultural practice of encouraging the use of caffeine in professional organizations. That's sort of part of our way of life. And I didn't really realize that what caffeine really is a drug that enables extremely unhealthy sleeping practices. So we think that caffeine sort of compensates for sleep deprivation, but it actually doesn't, okay? And actually the sleep scientist who wrote this book wrote it really as an exercise in public education, and my observation is it's very badly needed. So here's a case of a serious public health problem that hardly anybody is aware of. So I don't think we need more illustrations of the importance of education. So what can we do about it? Well, I was reflecting that some of the technologies we're talking about have shown themselves to be very effective in kinds of education that we don't really like. So people interfering with how people vote and their political positions, we've learned that these technologies actually can be used that way extremely effectively, too effectively in part. So I guess a kind of a flippant idea would be, maybe we can have a community service program for Russian hackers in which we enlist them not in doing what they've been doing, but in spreading knowledge about the kinds of problems that people in this room are dealing with and helping people to understand. You know, there have been so many examples. Andrea's poignant example of the tent with the kerosene lantern in it. These are people who don't know about carbon monoxide poisoning. That's an education challenge. So many of these things fit that. So can we think about how to use these technologies in the way that we use them for many other purposes? I mean, I used the one about the Russians, but we have a vast advertising industry that puts enormous energy into putting out messages about, actually many of them themselves rather harmful, one might say. So is there a way that we can organize ourselves to use these facilities for positive education for the issues that people in this room are interested in? So there's kind of a transition, I think, from this to the second theme that I wanted to mention. So an idea that I've been tried to promote so far without really any success, is the development of a technology that could be called social matching. So in many cases, the way education really works, despite the sort of top-down instances I've been pointing to so far, is through peer interaction. So people learn things from their friends. And for people with disabilities in particular, this is especially a powerful mechanism, because in the nature of things, people with disabilities have different needs and interests from people generally. And so being able to exchange information that someone in a similar situation to the one you're in can be helpful on all kinds of dimensions, including things like selecting consumer products. So if you're a person with a disability, reading the reviews on Amazon isn't going to help you very much because they're written by people whose needs and interests are different from yours. So can we organize technology in a way that's privacy respecting, which makes it possible for people to find people whose interests and needs are similar to theirs, and promote exchange of information, mutual reinforcement, and the like. So what that gets us to is the importance of the social dimension. So I was interested that Mohan Raj in particular gave us a couple of examples where that's being explored, but perhaps there's an opportunity to do more than that. We still, I think, are often thinking about a clinician-client kind of interaction as if that dyad existed somehow in isolation from the rest of the world, and sometimes, sadly, that does. We live in a society in which social interactions, social connections are not as strongly encouraged as perhaps they once were. But again, maybe there's an opportunity for us to use the technology that we're talking about to help people build their social connections as well. So I want to share an idea along those lines. Some of you may know Dave Gustafson of University of Wisconsin, electrical engineer. I attended some years ago now a workshop sponsored by the Computing Research Association, a visioning workshop on technology and aging. And perhaps you can imagine some of the kinds of things that were talked about there. A lot of stuff about smart homes and monitoring, a lot of stuff on fall prediction and fall detection. So falls are really a bad thing for old people. They fall, sometimes they can't get up. People literally can die from that. No question it's a bad thing. So people are talking about all the ways we can use technology to deal with that issue. And Gustafson stood up and gave a riveting analysis. He said, we really have a hold of the wrong end of the stick. He said, here's the story we should be thinking about. A person is living in a small, dwindling rural community. Their friends and family have died or moved away. They're lonely. They become depressed. They don't eat properly. They don't exercise properly. Their health deteriorates, and they fall. So the fall isn't the beginning of the story, it's the end of the story. So kind of in the same spirit, can we think of ways to help people strengthen use the technology that we're all interested in to strengthen and develop their social connections and use the social dimension in actually improving the quality of their lives, including things like adherence to exercise programs and other kinds of interventions. Again, like Mohan Raj, I'm really looking forward to hearing the results of that three-arm trial that he talked about. Thanks.
Thank you, Clayton, for very insightful comments. And about the coffee, and I'm a heavy coffee drinker, so it's guilty as charged. So next, Dave, do you do that? Yeah. Yeah.
We can do this roundtable style.
Yeah.
So formal. I appreciate it. Yeah, just a couple of things I'd add that they give me a good chance to get to the things that I forgot to cover when I was up here. I heard a lot about, especially in the kind of the underserved areas, about the high reliance or expectation you're always going to have video conferencing. I think there's this expectation that like FaceTime's so easy, but first of all, FaceTime's not always that easy if you can't get the actual bandwidth. But we're really focused on, in a lot of our population health initiatives, that it's that right care, right place, right time, right data, right care, right place, right time. And there's a huge opportunity for messaging, asynchronous messaging, image exchange, video exchange. I think live video is great if you can get it, but it's certainly not required. A lot of the tools that we're using and that we've invested heavily in do require that live interaction, but the downside to that is it's a one-to-one relationship. So if you think about a care navigator, a vocational counselor, anybody, if you're not available at the time, somebody's just sitting there waiting. Whereas if you've ever been on tech support with Xfinity, or I'm sure we've all been on tech support with Xfinity or Comcast, and you're chatting with someone, there's 20 different conversations that are going on. I don't know if that text translation, that's all being done like through the cloud and AI. I'm riveted by it, and it's amazing to watch. It's doing some sort of predictiveness where it thinks the words you're going to say, and then it edits the tense of the verb, and it's phenomenal, right? So, I mean, that blew me away. So right care, right place, right time was one thing that stuck out at me. The point about technology requiring interventions to be modified, I still remember back the first time we had a patient in, when we finally could get our video conferencing to work, probably on a dial-up modem or whatever it was, and we had a speech therapy patient was, Mr. So-and-so agreed to be my patient after hours. So my therapist friend, I'll bring him down in 10 minutes. We're in one office, and she'd be in another office, and then she disappeared. She came back 2 minutes later. She's like, well, when I have him in front of the computer, what do I do? And I was like, what do you mean, what do you do? You're the therapist. She's like, I don't know how to do this on a video. Like, nobody taught me how to be a therapist not in the same place. And now we're hearing that this is part of new training in schools and telepractice, especially I think in speech and OT and in some of those rehab disciplines. So that's exciting and sort of fulfilling for me. But even our emergency providers, our nurse practitioners, all of the how do you rapidly triage somebody, and how you can't palpate a wound, so you have to sort of be creative and use the tools you have. And then the last thing I'll put out, I was mentioning to someone before, so they did release yesterday, CMS's physician fee schedule for next year came out, and lots of things that look really promising at CMS, so who knows what will happen. But one thing that struck me, and where I think rehab always kind of just sort of falls to the wayside and people don't pay attention to it, there's a lot of focus on preventative care and population health and chronic care and chronic condition monitoring. And I've long argued, and I probably wrote a couple grants on this, probably weren't funded at the time, the same approaches we do where we think about hypertension, diabetes, like a stroke, a spinal cord injury, a cognitive impairment. They're disabilities that are chronic conditions that have to be managed, but they're not treated that way. So when you see things like CMS talk about, we'll give you 20 minutes to do monthly check-ins with your patient to manage their congestive heart failure. Okay, but what about the stroke patient? What about the ability to have some AI interface, tracking a depression screener score that might be coming across for 100 of your patients, and you're intervening and doing some calling. So maybe this is more, we're kind of in shouting distance of Capitol Hill here, but sort of pleading with folks to open up their definition of what healthcare really means, and don't just think about the sick care, but think about the longitudinal care of some of the patients that we're dealing with in our community. So I think I'll step off my pulpit now. I just broke your microphone.
Oh, okay.
Perfect timing. I broke.
Perfect timing for the microphone to break. So I still have the other one. So okay. So anybody, any questions, comments from anybody? Okay, sure.
For Beth, I want to hear what's happened with the youth pastor.
Bob had a remarkable recovery. He ran a half marathon 6 months after we met him, and he's back to work, and he has mild changes in his cognition. He gives me permission to share a story. He wants his picture on the slide, just so you know. He travels around the country between doing ministry and telling his story, but he had a remarkable recovery. He still has to compensate for his executive deficit, but he still uses strategy training 10 years later.
Any other comments? Steve, you want to? I forced Steve to comment.
things, this may not be the proper place to be saying this, but one of the things that I really like about the visitor platform and the idea of having a platform for developing telehealth applications is that it allows a lot of applications that are usable, secure, private, and integrates a lot of features and functions that are going to be needed in just about any context or environment. And the question that I have, and again, I might be out of place here, is that NIDLR is very interested. There's a number of NIDLR grantees that are developing things that are app factories, where basically you have a secondary dispersal of funds. Money goes to a grantee. They have some sort of system where they solicit people that want to develop applications. They provide support for the usability. They identify the market. They make sure there's a significant need met. They help frame the requirements. They help provide technical support. They help to assure the usability and accessibility of the application, especially obviously for the people that are going to use it. And then, because they're neither grantee, they have some way of tracking the adoption of the application, because as one of the speakers, I think it was you, mentioned, the review 300,000 apps or something like that, and probably a belly button full of ones that are actually relevant and useful to people. There's actually a systematic review that was done by John Morris that came pretty much to the same conclusion. 250,000 applications, and less than 50 really were fairly close, and probably 10 of them were actually being used, any significant number, which is ridiculous. So my question is, we have this convergence. We have people that are trying to develop these applications, and I'm just wondering whether something like the visitor platform could be generalized, where it could become a general platform for the development of general purpose applications that have all these desirable properties, a lot of which are significantly overlapping with telehealth. And so that way there, because we have a lot of people trying to get there.
Thank you, Steve. Steve is my program manager, so he's technically my boss in this project. So,
No, that's not true.
meaning, so thank you. So, yeah, one way of, what Steve mentioned is the app factory, meaning that it's more of incubator of, you provide fund for anybody with ideas and can come up there, and you disperse funding, and you selecting. It's more like competition. So asking students, university community, if they have any ideas that can build app for individual with disabilities, for example, and then you provide funding to build it, and then, as Steve mentioned. So and I had a conversation with Debbie yesterday, which is like, okay, so you build Visitor, and then why don't you just use any video conferencing system that is out there? That's another approach. So going back to what Beth mentioned about blending intervention and technologies, I think that's what we have been doing. So what we have been trying within the RERC is to build, in this case, both the Visitor and the I'm Here, is that we want to build generic platform that can be applied to many conditions, and by tailoring it to fit the intervention that we're developing. So an example, like iAdapt share many of the platforms as I'm Here. So that way we can build it faster than what it should be. And then and actually one of the side product of I'm Here that already going out, being commercialized, is for sleep intervention, for behavioral sleep intervention. So when Clayton mentioned it, I'm familiar a bit with that behavioral sleep intervention thing. So I think there are two ways of building the technology, and what we believe is building the technology is not easy. It's not easy. And Andrea mentioned that we have been working on the I'm Here, so almost in a way 10 years in the making, not only the effort that we have done lately, but also a lot of significant effort done earlier to figure it out, how it worked, the problem, my criticism with App Factory is that it'll be, probably easy, shallow app. And of course, the potential benefit of that one is that you never know what genius ideas out there from an undergrad, an 18 years old undergrad who want to build something, and that's possible. But what we learn is that building really meaningful app that fits into the intervention strategy is not easy. It cannot be done using 25K project. Okay, so it's just not possible. So I'm here, starting from when Brad and Andrea working with us, and then, probably hundreds of iterations, improving it, and we meet every other week, and for even 5 years now. So that the same thing with IADAP, it takes a lot of effort, from Beth, from my team, and Agus, from Emily, and so that's the thing that it either way could work, but what we have been doing is that it requires a blend of a significant effort from both the interventionist developer, so in this case Beth, Andrea, Brad, and technologies to blend it together and put significant effort to it. So.
Well, actually, I'm very interested in this general topic area, and I think that the point that it takes more investment, more time, more effort, I think that I actually agree with everything that was said, but in terms of the people that are doing app factories, they might say that it costs 25K investment for a secondary dispersal of funds, but they're providing technical support for the design of it, technical support for usability, technical support for committees to assess the marketing and significance. So you might, let's say that 25 actually scales up to 200,000. So then it's a much more significant amount of money. But the question is, so I'm speaking from the perspective of a government agency, my job is to try to ensure that the investment of public money is done in the most efficient, effective way possible. So I'm seeing that, a tool is being developed that can put out very high quality telehealth applications that are essentially integrating best practices in many ways, and it's still really hard. But if you can imagine the scenario, if you were using an app factory approach to develop telehealth applications, they'd be all over the place in terms of quality, and they'd be much more expensive. So the visitor it's not that it answers all questions, but it becomes a tool that raises the overall quality and speeds the process and lowers the overall cost. So I suspect that there's still a lot of challenges. You can't assure perfect usability. You can't assure perfect privacy. You can't assure that the semantic content of the applications is optimal. There are many challenges. I mean, we could go on forever. The challenges are forever, but it is a powerful tool, and it may be that something like that could underlie what are the App Factory projects now are a bit ad hoc. It would make it a lot more systematic, but there's still a lot of work to go. Would that be more reasonable?
Yes, yes, I agree. So what I think we have been doing sort of somewhat similar to that, although it's not systematic way. So what we have been doing is we have developed a platform and then try to leverage that to address a different condition. So that's So that's what we have been doing. So that's why, I had a discussion with Mohan yesterday. Why don't you use our Visitor 2.0? So, and the reason for that is being that we have invested on it. And so we know that area better. But you know the application layer better. So that's what the type of collaboration is.
I just want to mention that according to Banglade's characterization, I am also Mohan Plus. Since they're not using the visitor platform, your money is cut off tomorrow.
Okay. So that's the instruction one. So from Steve. So to save government's money. So so that way we could do more things. So yeah. So that's Mohan saw our our system on the booth yesterday, and then I remember that one of your project you doing many of the intervention like that. So we could claim. So that's an example, see, that we have spent a lot of time developing, computer, Clayton is computer scientist. Computer science people always think in terms of layers, everything, in terms of layers. So we have spent a lot of effort in building the lower layers. So that's the platform that, either I'm here or Visitor, and we'd like to leverage that, to collaborate with clinicians and interventionists to build the upper layer together from that one. So yes, so it's a bit different than App Factory, but the principle is the same. So yeah, so that's it's different. We believe that layers, the lower layers quality product takes a lot of effort, and that's once we develop it, it's there. So it's more like the open source thing, like people developing operating system, put it out there. It's better to put things on top of it and use it instead of building things from scratch. So that's the. So I agree. So I think the instruction is for Mohan to. Yeah. So any other comments? So yeah, Shiv.
Hello, I'm Shiv Harmat from Temple University. Thank you for the presentation. I understand the stacking, the interaction between clinicians developing the intervention. But when you do it in a pilot study, you have X number of iterations. You take it to a clinical trial, you have several iterations. But technology is also changing at the same time. So it's, even if it works at a clinical trial, what's the guarantee that it can ever be used in a clinic? Or maybe I'm naive about this, that it seems to, yeah.
Yes, that's not naive. That's reality. So yes, and actually within our lab, so we built the I'm Here system using cross-platform technology. Okay, and that technology is moving. Okay, so and right now actually, one of our students actually working on just transferring. So in this happened in just 2 years, is the platform, the code that is written is moving from 1 to 3, and the way it works is different. So assign one Paul is working on just transferring that too. So it's always a challenge. So that's why again that the point to the idea that it takes a lot of investment on that part. So that's what we have been doing. So but once that layers, the lower layers, move into the newer technology, again everything up will move that. So that's why it's important also to leverage, not building everything from scratch, and with the completely different technologies, and that will be much more difficult to maintain and also much more difficult to move. And so in the sense that your question about the interaction between the technology that moves all the time and then at the same time the research stage, you know, from pilot to other thing, those two are rather different in a way. So once we go to, let's say the IMU system right now is quite mature in a way, the platform. So moving to scaling up to other states, it wouldn't change much in a way. But again, yeah, so it's more like imagine things moving, but also the underlying, like the Earth is also moving. And that's what's happening in technology. And in fact, there is actually interesting paper coming out of somebody from NIH is in terms of research methodology. So when we implement it, especially for individuals with disabilities, because let's say in IMHERE system, they potentially use it for a long time. Our clinical trial is for 1 year. And potentially it could be lifetime that they use the system. So one of the challenges from the research is that if you do clinical trial for 1.5 years or 2 years, technology change. You know, I have an old iPhone and it still keep heating up. You know, Apple knows how to make me spend money for new. So everything changed. So that's and it's getting better. So better and better, and the intervention that we did. So an example, the intervention that we did with 1.0, for example, 2 years ago, could be completely different right now than if we use it. So that's one of the potential. I think Steve is interested also in methodological research methodology problems when it comes to technology intervention, because you cannot just stop, just keeping having the same thing while we know that things change. So, David?
So I think our project can really speak very directly to this. It's why there's a Visitor 2.0, is because we started out with Visitor, and then we started to have difficulties with Visitor because of changes in technology through the Windows operating system. So I think that what I would recommend is that we should think about this as it's going to be a chronic problem. I think it's always going to be keeping the intervention technology lined up to be effective in whatever the underlying technological forces are in the world that we're dealing with. And so I think the bottom line is that there's always going to be a need for more money to basically keep all of this going. So to Visitor 3.0 and 4.
But I actually, this is, I think, a nice digression. I think in terms of the money available, the money's always going to be a tight resource, and the need for the money will always be going up. And so the need for efficiency and effectiveness in what's being done will increase. So if we have approaches, I mean, I actually think the app factories are a good idea, but I think that the way that they're executed are not efficient or effective enough, not nearly. And so in order for those kind of approaches to be more efficient and effective, they need a technological base that is much more solid, and it's a lot easier and more cost effective to maintain one technological base that moves forward in time than for each of these centers or approaches to be trying ad hoc or semi-ad hoc approaches that will never, ever be as good as one unified approach.
I completely agree with that, Steve, yes. You mean, you'll give more funding, in a way? Yeah.
Well, to her, yeah, of course we will.
Any other comments or questions? Okay, so thank you so much. There's been quite a successful State of Science. So. Thank you to all speakers, and thank you.